Short video on carotid artery interventions. I'm not going to spend a whole bunch of time on this. If you ever need anything done, you need to spend time understanding the procedure that you're going to have. I just want to give you an overview of the main three options there are if you need carotid artery surgery. And so the three options we're going to talk about is the carotid endarterectomy, which is kind of the standard, I wouldn't say, I guess gold standard that's been done previously for carotid artery disease. And then there's carotid artery stenting. There's two approaches to carotid artery stenting. One is through the groin, where a catheter is fed up into the aorta and a stent is applied across the carotid artery narrowing. The other is this little nerve incision in the neck, so-called TCAR, where a small incision is made in the neck and the carotid arteries access that way and the stent is applied that way. So carotid endarterectomy, that's been done for a long time. I think the first person to do one is Dr. DeBakey, who is a well-known cardiovascular surgeon in Houston. But anyway, carotid endarterectomy, essentially what occurs is that narrowing in the carotid artery is removed from that part of the circulation. So remember, the carotid artery looks kind of like a Y. The one that goes to the brain, and then one that goes to your face. The internal carotid artery supplies the brain. The external carotid artery supplies the face. The common carotid artery is the blood vessel that goes up and splits into two to supply those lesions, to supply the brain and the face. Now, usually the blockages are typically at this, what they call a bifurcation, where it splits into two. It can be up and above and below that, but typically that's the location. And it's sort of got to do with flow dynamics, why plaque tends to build up in that area or blockages tend to build up in that area. So with carotid endarterectomy, there's different approaches to doing it. Some people like to do it under local anesthesia with sedation. Some people like to do it under general anesthesia. But essentially, you go into the operating room, an incision's made in your neck. Let's just say we're doing the right carotid artery. Incisions made in your neck here. You have the carotid artery lies deep to this muscle, which is called the sternocleidomastoid muscle, lies deep to that. So everything's retracted and the carotid artery is dissected free. And you go, essentially the principle of this stuff is like plumbing, going above and below where the problem area is so you can control it. And so the dissections continued superiorly and inferiorly. The common carotid artery is controlled, the internal carotid artery is controlled, the external carotid artery is controlled. If there's any branches, those need to be controlled. Because when you start the endarterectomy portion, you want a bloodless field that you can sort of clean that stuff out. But essentially, once this is controlled, then the patient's given heparin to thin out your blood while everything's being done. And so once the heparin's circulated, all the arteries are clamped, and then an incision's made through the area of blockage. Now, I'm old-fashioned. I shunt everybody and I patch everybody. What does that mean? So I put a temporary bypass down the clean area of the carotid artery and up the clean area of the carotid artery so that the blood flow continues to the brain on that side. That's just the way I was taught. I don't like to change. I like to do things the same way every time. And so I always patch and I always shunt. So the shunt bypasses the carotid artery and continues blood flow to the brain on that side. And then once that shunt is in, we just essentially peel out the blockage that's in the artery. Again, there's three layers of that artery: the intima, media, and adventitia. And so that plaque's built up in the intima media part, and so just that whole part is removed. Part of the adventitia comes out to the strength of the vessels in the adventitia. So everything's removed, all the little bits and pieces and little parts that are flakes that are left over, we take those out. And then since we're dealing with an artery, maybe half the thickness of my finger, I always patch this thing with a synthetic patch. It could be a Dacron patch or a Cortex patch, or sometimes we use bovine pericardium, which is pericardium from a heart that's been treated from a cow that's been treated to kind of not cause reactivity, but essentially patch this area over it and close that artery up. And then right before you get done, you pull the shunt out and close it up, and then reestablish blood flow to the brain. So that's the carotid endarterectomy. Depending on how difficult it is, can take an hour to 3 hours, depending on how severe it is or how difficult the procedure is. So then you go to the recovery room or the ICU, depending on your institution. You're monitored overnight, and you can go home the next day. Not a real stressful procedure. It's not real painful. Recovery is pretty good. I always put numbing medicine afterwards just to make it more comfortable. But then once you get home, you can expect some bruising, which is normal. You may feel a little bit of difficulty swallowing because of the swelling. I usually tell people, look, just prop your head up for like 48 hours to keep the swelling down to a minimum. But bruising, swelling, pretty much normal. What are the potential complications of the surgery? Well, one of the complications of the surgery is having a stroke from the procedure itself. Now, the risk of stroke from the procedure is fairly low, 1 to 2%, but still, if it happens, it's a bloody disaster. As far as I'm concerned, I think I've narrated or told before about the first time that happened on a patient for me, and I just could not sleep for 3 months afterwards. It was horrible. But anyway, one of the complications is stroke. So if I'm doing my right carotid artery surgery, I wake up, loss of vision in your right eye, or loss of control of the left side of your body. So when you wake up from the surgery, people will ask you, squeeze my hands. So they know that you're moving and you haven't had an intraoperative event. Or they'll say, stick out your tongue. Well, what's the deal with that? Stick out your tongue. Stick out your tongue midline. If it stays midline, you know that what's called a hypoglossal nerve, that's a nerve to that side of the tongue, is still intact, because that's one of the potential complications of surgery, is injury to the hypoglossal nerve. So stick out your tongue and motion. So that's the complications of surgery. The other complications is having a heart problem from the surgery. Having a heart attack or some kind of arrhythmia or irregular heart rhythm through the surgery does not happen very often, because anesthesiologists are so good nowadays at monitoring patients, and it's not a very stressful surgery in terms of it's not a deep anesthesia. It's not a very painful procedure. So then you're monitored. Back where I trained, we'd monitor them in recovery room. We'd monitor patients for 6 hours in recovery room, because we knew about 9, if there was any event that was going to occur, most of those events occurred within that first 6 hours. And if you're doing fine, then you just go into the regular ward and went home the next day. Now you can still have problems when you go home. I mean, you can still have a stroke, after 6 hours when you're hospitalized. That's always a potential concern. But the incidence just declined significantly. So the complications, hypoglossal nerve injury, where you have deviated tongue. Sometimes that's just from traction, but sometimes it's an injury to the nerve itself. Stroke, heart attack. Sometimes you'll have a injury to the what's called the mandibular nerve, the muscles to the face this side, usually from retraction. Because we have to, this structure is sometimes deeper. You have to retract, and so you have a slight droop on the lower lip on that side. Usually that resolves with time. Other potential problems with it, difficulty swallowing. If you get a hematoma in here, you can have difficulty swallowing, especially solid material that's not soft and easy to swallow. So, difficulty swallowing. If you have a dissection that goes up very high, then swallowing problems can be a problem, because that swallowing mechanism is up higher. And so sometimes you'll have difficulty swallowing, just not from the swelling so much as from the high dissection. And that can be a problem. I've had that happen before to patients. Usually it goes away pretty quickly, but I had a patient that had that for like 3-4 months. And it's very distressing, obviously, to everybody. But usually that gets better with time and with therapy, with a swallowing therapist that helps with all this stuff. Um, Probably the dreaded complication, which I'm almost scared to, I mean, shouldn't say scared, but one of the potential complications is bleeding inside the brain. Now, that's pretty dang unusual. These 29 years or so I've been doing this stuff, I've maybe seen 2 or 3 out of thousands of these procedures. Uh, that's a real problem. If you bleed inside the brain, sometimes it's minor, sometimes it can be devastating. But again, I mentioned all the potential complications, but in reality, your chances of having a complication from the surgery is maybe 2 out of 100, 2 to 3 out of 100. And if you've had a symptom of a TIA, your risk for stroke is significantly higher. And so in that situation, you need some kind of intervention done. So that's carotid endarterectomy in a nutshell. Now, carotid artery stenting, the transfemoral approach is going through the groin crease and essentially putting a wire up through this area and getting across the blockage. So temporary filters are placed above it so that when the stent is applied across that area there, this filter catches debris that can potentially go up there, and it's fished out, and then the stent is applied across the lesion. With the carotid stenting, you're not really taking that plaque out, you're just reopening that channel again. And same thing with transcervical carotid stenting. So a little incision here, just go straight up. We usually put a reversal flow mechanism in, so the blood flow to the brain is temporarily reversed in direction, so that any debris goes down, it's captured in the filter. So the reversal flow makes the debris go backwards. It's captured in the filter. So that's the transcervical carotid. Again, a small 1 centimeter incision to do it. Recovery is really nice. And the data from the Vascular Quality Initiative seems to really kind of favor the transcervical carotid stenting in terms of complication rate. Now, the long-term data is not available. 10-year data is not available for this stuff, but it seems to be doing really good. The problem with transcarotid stenting is it doesn't work for certain conditions, like if the plaque is heavily calcified, it just doesn't open up very well with stents. So if you have what they call circumferential calcification, the entire plaque is just surrounded by heavy calcium. When you put the stent in, it just doesn't open up very well. So those are probably situations where carotid artery surgery is a better idea than actually removing that stuff. But the TCAR is a really nice way, and this specialists do a lot of them. My partner is a instructor in TCAR, and she does it beautifully. So there's advantages and disadvantages. I think if you ever need either one of these treatments, you just need to really kind of discuss the pros and cons with your interventionalist to make sure it's right for you. Assuming the indications for carotid surgery are there for you, or carotid intervention are there for you. The TCAR and the carotid stenting, potential complications of strokes, obviously, from the procedure. And again, the risk of stroke is actually not that high from the procedure. Either way, I actually, I think things are heading towards doing more TCAR, and maybe overly so, and they may swing back. So somewhere down the line, the pendulum is going to kind of settle, and the absolute indications for each 3 of these modalities will be available. The issue that I have with the transfemoral stenting is that you're putting wires into the aorta, and sometimes the aorta has atherosclerosis in it, and so part of the problem with the transfemoral stenting is these wires, you direct them very nicely, and people are very good at this stuff, but still there's plaque in the aorta, and sometimes that plaque can break off of the wires and go up the other side. So one of the potential problems with transfemoral stenting is that you're trying to fix the right side, and all of a sudden you end up with the left-sided stroke because plaque was broken off from the aorta and went up to the left side. Now, again, that doesn't happen very often, but that's a concern because that's not what you went for. You went for the right side. Again, it doesn't happen very often, but that's why TCAR, transcervical carotid stenting, kind of takes this system out of it. So it gives you direct access to the carotid artery. But anyway, time will tell. I think what I would suggest is if you have a carotid artery stenosis that needs surgery, make sure you get an opinion about all three ways of handling it. Because, sometimes we have our own biases, I think, in terms of which way to fix it. It's not probably a conscious bias. Although I don't do transcervical carotid stenting or transfemoral carotid stenting, so I will, recommend carotid artery endarterectomy if the lesion is highly calcified, and I think won't work with the stent. Otherwise, if I think it'll work well with the stent, I'll have one of my partners who does the transcervical carotid artery stenting, the TCARs. I'll have them do it. But get an opinion, get a second opinion if you're uncomfortable, but discuss all three modalities and see what's best for you. Addendum. One other complication I didn't talk about in carotid surgery is vocal cord paralysis. So the nerve to the vocal cord on each side is supplied from a branch of what's called a vagus nerve that travels over the jugular vein underneath the carotid artery. And so one of the potential problems from carotid surgery is that nerve to that side of the vocal cord is paralyzed either permanently or temporarily. And so the symptoms you'll get from that after surgery is difficulty with phonation, speaking. So your voice will be very raspy. Now, sometimes that's just from breathing tube being in there, but sometimes the injury to the nerve means that vocal cord on that side is not moving, and so your voice will remain permanently raspy. Now, ear, nose, and throat surgeon can inject that vocal cord with Teflon to kind of straighten it out and make your voice better, but that's a potential problem with the surgery, is vocal cord paralysis. And then, if you get a big hematoma, it can compress not just on your swallowing mechanism, but your trachea, and that's why we monitor people after the surgery. So those are the two kind of other issues that can occur with carotid surgery. Again, they're pretty unusual, but that's something else to kind of look for. But I just thought I'd add that because I forgot to talk about vocal cord paralysis during the carotid complication that we were discussing earlier.